Happy to be here today. My name is Alicia Vossia and I'm a GP ST2 in Scarborough GP training scheme. I'm currently working in Slides and Sons and medical practice, where I was also a planetary health innovating training post trainee. And this is where the project came from, and also from inspiration from greener practice. Bit of background and inspiration for the project. Our patients are affected by chronic pain. It affects even 30–40% of adult UK population. And this contributes highly for prescribing of pain medication in primary care. And if we look at the primary care at total, prescribing is 60% of carbon footprint that we're responsible for in primary care. And as planetary health trainee at the time, looking into the goal that we have, which is NHS net zero by 2040, and also the goal of improving the care we give our patients. I looked at this project as a bit of challenge of how we can do that. How can we reduce the prescribing, which is high carbon, and how we can help our patients. To start with, I looked into open prescribing websites at the data of pain medication in my practice. We were quite good for the opioids. We were below national average. We were above national average for pregabalin and gabapentin, and this is the reason why I picked these two medications to look at. My methodology was to look for patients through System 1, which is the computer system we use in primary care. And that's how I found patients on repeated gabapentinoid prescriptions. Put some exclusions, which was patients with cancer, neuropathic pain, and palliative care patients. Further, I did some clinical manual screening because this automatic one wasn't perfect to pick my patients, and that's how I identified 45 people who were suitable. I sent them invitations. It was an SMS message through IQRX. 14 of those people decided to go for it and have a 45-minute consultation with me, where we were introducing the pain story framework. We were talking about pain, we were talking about side effects, and we were together looking at different things and different approaches we could take to help them deal with it on an everyday basis. After that, depending on what was needed, if patient decided to titrate the medication, I was giving them a call after 2 to 6 weeks, and then some of them decided to complete anonymous survey online, and we were also looking into prescribing. Before I go any further, I would like you to meet my patients and kind of show you a little bit how I was trying to approach it. My question at the beginning of this wasn't, what's the matter? What is the matter with you? I wanted them to open up and I wanted to say, what really matters to you? The patients were mostly female. They had various diagnoses. Quite often it was more than one for each of them. It was spinal problems, systemic problems, it was osteoarthritis. And what was really interesting when we were starting to talk about medication, 12 out of 14 suffered side effects of the medication they were taking. It was quite often cognitive problems. They were complaining of brain fog, concentration difficulties. They were dizzy. Significant one was a weight gain. The one that was really kind of emotional for both patients and me was mood changes and anxiety and anger. Why not? I scrolled too far. Yeah. So what we were doing is after initial introduction about the pain and after initial introduction about how it's affecting them and side effects, we were introducing different things. And I must admit, in the beginning, I was like, oh, I'm going to screen these patients with standardized questionnaires. They're going to answer my questions. I will offer everybody everything, but it didn't work like that. It was really patient open, and this is the reason I put these two things in a center, because the main things was the connection and the time, because there was a very long consultation. And looking at the results, I appreciate it was quite a small group that I met. We had some quantitative impact. Interestingly, when talking about medication, 10 patients of 14, which is 71%, were open to titrate their medication. They said, this is something that could happen for me. The project has quite a short time frame, so not everybody was ready to do it at the moment. Some of them were carers for palliative care patients. Some of them had different life issues at the time, but they stated they were open to do it at some point. 4 of them did titrate their medication. It was either completely stopping it, or it was reduction. And what is incredible, I calculated it through the NHS tool, which is Breast QAP carbon saving tool. It uses a formula based on the cost of medication. And if you look at the environmental impact, it's like over 1,000 miles driven in a car, just 4 patients producing a little bit of the pregabalin and gabapentin. It's like planting 14 mature trees for 1 year. So I think it's quite impressive based on the carbon. The more important thing, I was looking more into qualitative work rather than quantitative, considering my small group. And this is what patients said. They said, I'm surprised by how my mental health affects how I cope with my pain problems. They said, it's helped to talk to a doctor who had time to listen. I try not to talk to family or friends, as moaning doesn't help anyone. There were tears, there were different, it was quite heavy, the consultations, but it shows how the safe space itself, I didn't have to tell them to meditate. I just listened. I just gave them 45 minutes and listened. They also said, the mindfulness helps, so I do it. Or they said, I'm going out to church a bit more, helps to distance yourself from perpetually thinking about pain. And this is giving patients the power. This is empowering our patients and saying, you don't have to just passively take your tablets. You can actively manage your pain. It's in your hands. You can do it. It is also some patients who decided not to titrate their medication. They said, it's a relief to know I can stay on my low dose. It does help me function. I also know if I want to lower it further, there will be the help for me in the practice. So it's important to say that this deprescribing that we're trying to achieve here isn't just taking things away. And that was something that I really needed to explain to patients. Like, I'm not going to take anything away from you. That's fine. I'm just going to talk to you. If you decide to do it, we can do it together. And I think this perspective is really important to explain to both patients and doctors. I'm not taking things away. I'm just offering you something different. And this brings this discussion, because I was really privileged having the time. I was trainee on innovative training post. I had all the time. I could do it. I could have 45 minutes to speak to these people. But is it sustainable to have 45 minutes to talk to just one person? GPs have 10 minutes. If they're very lucky in their practices, they have 15. But then if we look at how much time every day every GP spends to issue another prescription, how much time will they spend on another consultation dealing with patients' weight gain, with their anxiety? Maybe thinking it is sustainable, because we're addressing the root cause, we're giving patients the power, we're empowering them to do that. And it's time-intensive, and we're giving them our time as well, which they said, I just needed somebody to talk to. So I do believe in this conclusion that I wrote here, that bespoke lifestyle interventions are the key to our goal of NHS net zero. And the patients, and I think I would even say more, I think patients and clinicians, we both need to believe that their approach to pain management isn't just giving people more tablets, it is to giving them tools as well, and empowerment. Thank you.
Mr. Hodgin, you do get full marks for coming in under time by the 9.5 minutes.
Questions then.
There's one other question. Any questions, but it includes the judges. They can ask questions as well if they're not clear about any part of the talk. So thank you for that fascinating talk. I won't ask any questions at the moment unless nobody else comes up with things, but thank you so much for that very interesting talk. So any questions from our esteemed audience here today about that?
Yeah, and what sort of interventions do you offer? And are we like prescribes on the practice, for example, you said about social?
Yeah, I kind of cut this slide short, to be fair. So first thing, it was important to understand where I was, and I was just starting in this practice, and it is quite a rural area. So first thing that I would quite often offer to people is there is a charity around Moors there called Revival, and they offer exercise, and they take people to this exercise. So it's a bit of a social connection and a bit of exercise. Then at the time when I was doing that, we had chaplains. So people who said, oh, they really appreciated the talk, they would be referred to chaplains. I had a website with meditation. So we were kind of going into it, and some patients were like, oh, no, I'm absolutely not going to meditate. And then we would take a step back. But some of them were like, okay. And then I would kind of elaborate more, saying, start slow, and then you can do it. And it was like kind of all body relaxation. Quite a lot of them, because weight gain was significant, were referred either to our nurses, or there was this website, Live Well with Pain, that offered diet plans as well. We could refer to everyone active as well for exercise. Yeah.
So basically, you were not just deep prescribing, but you were
No, there were many things. Yeah, I just kind of cut this slide. That's why I was faster in time.
Thank you so much.
Yeah.
That was not ontological intervention.
Yes.
Yeah. Another question from
Hi, thank you so much, Lydia. I just wondered what your practice think about whether when you on to your next.
So what I did for the practice is all these things that I put. I created a thing called kind of chronic pain toolkit, and this can be either sent to our patients or used by the practitioners within the practice. And it has like different parts. So some of it is for some people, understanding the chronic pain is important. So there are some resources for patients to do that. And there are some, all these resources I mentioned with the previous question. And also titrating plans. So we would have a certain document, NHS document, where we could do, it was like, it worked really easy because it's like a table. So basically, if you want pregabalin, this dose, next week we go on this, and then we have another 2 weeks on this. So it was like a very easy titrating plans. And they were really on board. They were happy because I was doing medication reviews as well and clicking them. I mean, I can always go back on open prescribing and see how we're doing, but I do understand there are also other people who are not getting it. But also, quite often, the patients that I saw during the project are coming back to me, and some of them are on further road to deprescribing. So one of the patients that I got off pregabalin, she's like, I don't want to be on amitriptyline anymore. Can we do that? I was like, okay, let's try.
Wonderful, thank you. I should just point out there is at least one person on Zoom. So hello to the person on Zoom. I'll try to remember to repeat the question. It's being recorded. It's being recorded as well, so we will repeat the question if we can. So any other questions from the group here? Yes, Penny, yeah.
30% uptake, you said you identified 45.
Yes.
Some 14 or 15. How do you think you might reach the other 30?
So I think the reason
There were 45 in the study and only 14 opted for the intervention. How could you reach the others?
So I did have a think about it, and some of the patients I tried to reach again and ring them and explain I'm not going to take things away from you. Some of it was the time frame. So probably some of them weren't available at the time when I was doing it. But I appreciate those who showed up were more open to this intervention. So this kind of takes it. That's why I kind of point the fact that the group is small and bit of a chosen from people who are open to the intervention anyway. I understand. If it was a different type of project, I would probably kept going and reaching to them, but I kind of accepted the quantitative outcome, and I think it will be kind of like a waves on a lake. If you like, it got to the practice that we can do it, and I have people send in patients who need titration of medication to me. So I think the effect will be slightly better, and I'm happy with that because I'm not treating it like a strictly scientific, I would say, and I'm kind of happy with the way it went.
Your reputation influence will spread like.
I hope so. I hope so a little bit because, as I say, well, like one patient who reduced their dose are happy to do with different medication.
Yes.
And some people say, I know there is a help in the practice if I need it, which I think are amazing words to hear.
Your carbon footprint analysis as well. So put your hands together, everyone.
Hi everyone, thank you so much for the invitation to attend this kind of fine establishment today to present my work on irreversible electroporation and renal cancer. My name is Vincent, I'm one of the interventional radiology registrars in Leeds. So we've been observing for the last few years that there is an increased incidence of renal cancer because of incidental findings on cross-sectional imaging. As you can imagine, we are literally CCing everyone and doing ultrasounds on everyone nowadays. Yeah, we have detected a lot more renal masses, but then whether they're malignant, they're another story for another time, and how much they actually impact patients. This creates a dilemma, really, especially when we're treating renal cancer, is that do we only focus on overall survival and oncological outcomes, which are very important for surgeons or interventional radiologists doing the procedure, or do we also focus on things that are important to patients, such as quality of life, complication rates, and renal function? And this is especially true in patients who've got hereditary RCCs who are repeatedly treated for their de novo tumours. So I want you to keep in mind with the trifecta. This is a trifecta that we established from literature, taken from surgical literature really, that to consider treating a small renal mass, we should make sure that important is that we don't have a less than 25% drop in EGFR from baseline, no major perioperative complications, or to achieve a primary technique efficacy or a negative surgical margin. Then obviously the gold standard for treating renal mass is a partial nephrectomy. So essentially what we do is we chop the bit of the kidney with the tumor in, suture back up, and that's done. Sounds simple, but it's not really that simple. You've got complication rates that's quite relatively high. You get 20% of patients actually end up having CKD over time. And for patients with the endophytic tumor, which are tumors that is in the parenchyma itself, rather than exophytic growing outside, the trifecta is about 45%. And a procedure performed by interventional radiologists or interventional oncologists is image-guided cryoablation of renal tumor. Essentially, what you do is that under CT guidance, we stick a needle into the tumor that grows a nice ball around it, inducing necrosis, essentially causing cancer cell death. Of course, there are some limitations of this. So this is what we call heat sink effect. So if you imagine we've got ice ball treating the tumor, but then you've got vessels bringing in and out warmth, blood is warm, that would actually lead to an incomplete ice ball and an irregular treatment margin, and therefore reducing treatment efficacy. You've got endophytic tumors, as discussed, that are quite close to collecting systems and also to the hilar vessels that can increase rate of complication by damaging these vessels. And again, sometimes you can always have bowels that are quite close to the tumor, which can cause collateral damage. And in endophytic renal tumors, the trifecta rate is about 58%. Then this leads to a patient with a met need. You've got patients who might not be fit for partial nephrectomy because they might not be fit enough for it, or they have repeated treatments, or those that are not suitable for ablation because they are the position or location of a tumor does not allow that. And that leaves them with a radical nephrectomy. And this is particularly, again, not applicable for patients with solitary kidneys who've got already a low renal function and hereditary diseases. So I'm sure in your practice you'll observe patients go on dialysis, and it's not a really pleasant thing to have for patients. So hopefully what I'm going to describe is going to provide an extra lifeline for patients in this group. So this is just a quick video if it works. If it doesn't work, don't worry. That's okay, I can talk about it. So this is my dear mentor, Professor War in Leeds, who's performing an IRE procedure in the CT scanner. So what is IRE? So this is irreversible electroporation. So essentially what you do, you put electrodes next to the tumour under ultrasound guidance or CT guidance, and then you deliver a high electrical pulse that is gated by ECG or by heart rate. So what essentially it does is that it punches many million, thousands of nanoholes on the cell wall, which causes what we called irreversible or reversible electroporation, and it causes homeostatic disruption. So you punch all the holes in the cell wall, or the H2O will go in, or water go into the cell. You get ion balance, you leak all the ATP, and then it leads to cellular failure, which leads to apoptosis and necrosis. And that's how RE causes cell death. And the advantage of it is that it's non-thermal, so it's not affected by heat sink effect at all. It's highly selective and collagen sparing, so it preserves vital structures such as vessels, collecting system, and the ureter. And it also have very precise ablation margins, so it reduces chances of incidental bowel injury. And most importantly, it gives a lifeline for those otherwise would have progressed to advanced disease. So I want to introduce to you the REWIDE study. This is an international retrospective case series aiming to inform the latest practice of IRE in renal cancer. We've involved 3 sites across the world, which is in Leeds, Miami, and Madrid. We included all patients age over 18 with a biopsy confirmed or presumed RCC, if they've got hereditary disease, that are still localized and they're undergoing irreversible electroporation between May 2015 and October 2024. And all these patients are discussed within the MDT and deemed not suitable for partial nephrectomy, radical nephrectomy, or conventional image-guided ablation. All procedures performed under general anesthetics for deep neuromuscular blockade, and sometimes we do a ureteric stent preoperatively to prevent ureteric injury. So this is an example of a renal tumor in the right upper pole. As you can see, coronal images. We've put 6 needles surrounding the tumor. And at 1 month and 6-month follow-up, we have induced necrosis in the treatment area. So the outcomes that the study is looking at mainly is primary technical success, and other outcomes include primary technique efficacy, secondary technique efficacy, local control, oncological outcomes, renal function and complication outcomes. And of course, trifecta we talked about. Data analysis performed using Stata. We've performed sensitivity analysis as well, just to make sure that the specific effects of treatment are from the IRE rather than salvage therapies, such as repeated, well, eventually some patient had received a radionephrectomy or nephrectomy. So we want to make sure that all the results are due to IRE rather than any other therapies. Total of 68 patients with 71 renal tumours were included. We've got a mean tumour size of about 3 centimetres, and almost all of the tumours were less than 1 millimetre from vital structures, such as the ureter, vessels, or bowel, and just over half of them are all endophytic and hilar. They were performed under CT or ultrasound guidance, and the mean number of electrodes of 4.5. Technical success was achieved in all patients, and this is defined by a complete treatment of the tumour according to protocol and complete coverage of ablation zones immediately post-procedure. In terms of primary technique efficacy, and this is defined by not having any evidence of residual disease on the first follow-up scan, and this is about 77.5%, and this decreases significantly as tumour size increase. 14 patients underwent further treatment, and this leads to a secondary technique efficacy of 80.3% and a local control eventually of 95.8%. Unfortunately, 2 patients passed away due to unrelated disease prior to retreatment, and 1 passed away due to metastatic disease at 24 months. We have demonstrated good survival oncology outcomes of a mean duration of follow-up of 59 months. So overall, 5 years, we've got local tumor progression-free survival, or more commonly known as local recurrence-free survival of 84.4%. Got a metastasis-free survival of 91.4%, and a cancer-specific survival, which is great, of 98.2%. And a sensitivity analysis, excluding patients undergoing other modalities of ablation, has shown no significant difference. And the numbers are a bit too small to allow for multivariable analyses. We've observed 2 major complications, and one's permanent ureteric injury require permanent stenting, and one's hematuria that resolved after stenting. And this is notably actually lower compared to cryoablation or robotic partial nephrectomy in complex endophytic cases. And renal function-wise, there was a mean EGFR drop about 5 post-treatment, and just about 10% developed a clinically significant EGFR drop of less than 25%. And these are comparable outcomes to other thermal ablation modalities, but they're superior to robotic partial nephrectomy, which was a 15.5 decrease. In terms of trifactor, our study demonstrated a 64% trifecta rate, which is, although not directly comparable, completely endophytic tumors in thermal ablation and robotic partial nephrectomy achieved 58.8% and 45.4%, respectively. So this study outlines outcomes of IRE in patients who otherwise would have been ineligible for definitive curative treatment. And our group, our cohort, arguably include more complex tumors than cryoablation or robotic partial nephrectomy in literature. We have mildly larger tumor size, we have lower large tumor size, and also more close to vital structures, but we have a lower complication rate and a moderate local tumor progression or recurrence-free survival rate. That's just between partial nephrectomy and thermal ablation. And the trifecta rate, that's slightly higher than the other 2 as discussed. So in conclusion, we believe that IRE may offer superior efficacy in achieving optimal outcomes for the most challenging endophytic tumors that are close to vital structures. Next steps. We believe that more retrospective data and paired cohort analysis compared to cryoablation or partial nephrectomy is required to really establish the role and position of IRE in renal cancer. It's also very interesting to see how we can use immunomodulation to treat further metastatic or advanced disease cohort utilizing their non-thermal properties. And that's the end of my talk. Thank you so much.
That was Vincent. It was 12 minutes there, but you did really well there, quicker than an interventional radiological intervention. It's almost the same speed. So thank you. So people might have questions about the content and some questions about the methodology of the study.
Yeah.
So I'm going to open it up to the audience now. Yes.
Yeah.
So it really looks like it's going to be life-changing new modality in renal cancer treatment. And as a core surgical trainee, I really appreciate that. It's a very good relief from our shoulders to yours. Yes. So my question is, if this IRE kind of technique is even quite effective in complex, otherwise non-eligible patients, why it's not used as like first line treatment in renal cell carcinoma? And also, have you received any kind of fundings or any kind of like randomized control trials organized by any kind of company? And just 2 questions from my side.
So thank you so much. So those are 2 questions there. The first one is, why isn't everyone being offered the IRE intervention if it's so wonderful? The other one is about funding and background. Thank you.
Thank you. So just to answer your first question, IRE, it's incredibly complex to perform. Prof there has been doing it for about 20, 30 years, so she knows what she's doing. So it requires very delicate placement of needles. It's very highly technically challenging. So this is a skill that other places have not adopted yet. So it is very tricky for it to be first line to start with. But then also we also see the traditional cryoablation modality is actually get really good outcomes. You get primary technique efficacy of about over 90% and very low complication rates without those limitations that I talked about. So clinically, I think kind of benefiting how complicated the procedure is and balancing with the clinical efficacy, it is currently more cost effective in terms of time and the probes and stuff, and also skill of the operator to still offer cryoablation or partial nephrectomy in patients that are really fit to start with. And we see partial nephrectomy has a really good oncological outcome. So again, it depends on what is really important for the patient. So I think part of me feel like we should move away from, oh, this is first line, this is second line, this is third line, but more like what's important for the patient. If the patient values low complication rate, then yes, ablation, IRE, they go. If they value oncological outcomes or low recurrence rates, then yes, by all means, offer for a partial nephrectomy. So it's a personalized discussion between the clinician and the patient rather than I feel like what's first line and second line. But I think from both cost benefit point of view and also from what really benefits patient point of view, I think that's probably why we've not really offered it very, very first line. But again, it's down to discussion. And in terms of trial and costs, this is again very specialized technology again. So it is there are talks about it, but then we're not really there yet. I think even for liver tumors, somehow it got the label this labeled as off label for it now. So I think there is a lot of work to be done. There are companies that are very keen to, and then now more IRE machines that are out there. So hopefully we'll be able to get a bit more funding to take it to the next step. But then, as I said, we need a bit more retrospective study to prove that it's safe efficacy before we can go on to actually doing large trials to compare them.
So I'm going to count that as 2 questions, if that's all. Really, like just one more question to keep the time. So I think that's got a question. Phil,
you said it was selective. The injury was selected to certain tissue types. I think wasn't.
Yes.
It didn't injure collagen.
It's collagen sparing, yes, indeed. Yeah.
And other tissue sparing as well. Other types of tissue.
So how sparing it is, it depends on, the amount of collagen in it. So if you've got the collecting system and the vessels, they're high in collagen. So that's why it's tissue selective in that way. So it doesn't damage less. And the idea of, the other bit of it is that because you have to put the needle surrounding the tumor and the currents only go in between the needles, rather than heat, you can't really control where it spreads, well, less so. Or ice ball, you can't really stop cold from dissipating out. But then with IRE, you limit the current within where you want it to be. That's why it can be highly selective. And also collagen sparing, it's also part of that as well.
How does it come? How does the electric current spare collagen?
That's a great question. Yeah. I'm not sure. I guess I'm by no means physics expert. So, but I guess obviously it's something to do with probably cell wall being thicker and more tough when they're more collagen containing, that it wouldn't cause that hole to be punched or require a way higher threshold for it to punch a hole in it, essentially. So that's my
it's also the radio modulation of the fibers in the protein structure. Just to say about the cutting-edge of technology here, depending it's aside now. It's such a high-tech talk, and for the right patient, I'm sure it's based on radical nephrectomy, a brilliant intervention. So put your hands together one more time for Dr. Lee.
Thank you.
I spend my days looking after babies like these on the neonatal unit, preterm babies, and it is a wonderful job. We have the privilege of looking after children and their families at a critical time in their lives where they're very vulnerable. But it's not all good news. And sadly, in the UK at the moment, Black babies like Sam are more likely to die in infancy than white babies like Alex. But why is that? And more importantly, what can we do about it? And that is the talk that I'm going to deliver to you now. So this graph is taken from this paper, and it shows that as deprivation reduces, mortality reduces in infants. But that is different according to different ethnicities. And that ties in with some high-profile papers, reviews, and reports looking at maternal experiences of obstetric care and midwifery care. And very sadly, we see much higher rates of complications for Black and Asian women. That means high rates of hemorrhage, preterm birth, stillbirth, and mortality. So that there is evidence of a difference in outcomes. And that led to our research question tonight. So we wanted to know, as a group of neonatologists, does perinatal care vary by ethnicity and socioeconomic deprivation? Or to put it more plainly or bluntly, are socially deprived or minoritized, ethnically minoritized groups receiving measurably different care in hospital? And if so, how can we rectify that? We explored this question using data from a national data set called the National Neonatal Audit Programme, or NNAP. And our hope was that if differences were identified, that would be an opportunity to intervene. It was a retrospective observational study over using data from a period of 2017 to 2023. We needed demographic data. The babies had to be at least 22 weeks gestation, and just for 40 weeks is a full-term pregnancy. And they had to be over 250 grams because it's not physically possible to resuscitate babies smaller than that. The exposures were ethnicity, according to the Office of National Statistics, and deprivation. The outcomes we looked at, these are all evidence-based interventions that improve mortality and morbidity or parental experience whilst on the neonatal unit. So we looked at birth in a centre with a neonatal intensive care unit, and that's vital for babies born before 28 weeks. Antenatal steroids, which help the fetal lung mature, magnesium sulfate, which reduces the risk of cerebral palsy, deferred cord clamping, which helps babies to stabilise when they're born and reduces the need for blood transfusion, and normal admission temperature, also associated with mortality. And then some care processes on the neonatal unit, whether or not the children receive non-invasive respiratory support, that's much safer for a neonatal lung, whether they were followed up, whether or not the parents were updated about their child's progress when they've been admitted to intensive care, such a basic thing. And then breastfeeding, and there were 3 measures of that. And just to point out, that first one, and within the first 48 hours, that's not really about nutrition, that's about the immune system. So breast milk contains immune factors, and whether or not a woman wants to breastfeed in the long term, it's important to get that early breast milk for preterm babies to reduce mortality. But it does take coordinated efforts between a midwife, a nurse, the mother and the baby as well. So it's not something the mother can do on her own. We did a logistic regression analysis, adjusting for lots of maternal and neonatal factors, and calculated predicted probabilities based on the model. So looking at some results, when we excluded cases with missing covariate data, we had a sample size of 124,155 babies. And this is the breakdown by deprivation and ethnicity. So you can see here that as we get more deprived, sorry, you can't read that from where you are. This is least deprived, this is most deprived, and all the bars get bigger because prematurity is associated with deprivation. The white group is the biggest in all of them, but you'll notice that the Asian and Black groups get to represent more of the group as we get towards the more deprived groups, because there's also an association with deprivation and ethnicity. So now, if you like graphs, you are going to love this. If you don't, you're just going to have to bear with me, okay? So what we've got is all the outcomes are going to be over here. Odds ratios on the bottom, line of no difference here at 1. So we've got least deprived to most deprived, and the comparison group is least deprived. So first outcome, birth in the centre with NICU. So we've adjusted for ethnicity here. This is just looking at deprivation. And we see there's no difference here. And antenatal steroids, no difference. Magnesium, no difference. Deferred cord clamping, no difference. So we're providing equitable care according to deprivation for these measures. Similar with admission temperature. The more deprived babies are less likely to receive non-invasive respiratory support. The more deprived babies are less likely to, their parents are less likely to be updated about their progress. And look at this relationship with breast milk. It's quite striking, gradient response here. And more deprived babies less likely to be brought for their follow-up. Then with ethnicity, just to get your eye in here, our comparison group is white, which is shown in purple because white would be invisible. And we see that black babies are more likely to be born in a centre with a NICU. And again, we're providing equitable care for steroids and magnesium. But if you look at deferred cord clamping, there's definitely some interesting results there. And also Black, Asian and mixed ethnicity children less likely to have a normal admission temperature. White babies less likely to receive non-invasive respiratory support. Asian families less likely to get an update about their child's progress when they're on intensive care. And then this breast milk data is interesting. So white children are less likely to go home on breast milk, but they're more likely to get that early breast milk that requires the help of the clinicians. It slightly implies the clinicians aren't approaching those mums to help them express in the early few hours. And then Black children and other ethnicity children less likely to be brought for their follow-up. So there's tons of results there, and I can't talk about them all now, but I would love to talk about them later. But I'm just going to talk about deferred cord clamping. So this has, in extreme preterm babies, a 30% reduction in risk of mortality. I would challenge you to find an intervention which is free and is carried out in less than a minute that has an impressive reduction in mortality. So it should be the standard of care for these babies, and yet the Black and Asian babies aren't getting it as much as the white babies. So there's a couple of reasons why that might be. So if we do immediate cord clamping because we need to start chest compressions on that baby and resuscitate it immediately. So that might be that these babies are being born in worse condition because of their obstetric background. That's not great. But it also might be that trainee doctors like me aren't as good at assessing a baby with a different skin colour at birth. Because pink is one of the things that we factor into whether or not we clamp that cord. And these are predicted probabilities based on the regression model. So just to get your eye in here, we've got ethnicity along the bottom. So white babies over there, then black babies, and then within that split up by deprivation. And this is just to show that, and we've got probability of receiving deferred cord clamping. So about 55% of white babies got deferred cord clamping when they were born preterm. But even the most deprived white child was more likely than the least deprived black child to receive the deferred cord clamping. So this isn't a story about deprivation. It is literally about their ethnicity. Okay, so there are some limitations, obviously. So we had some missing data, but we did still have a large study size. We had to restrict to babies admitted to the neonatal unit. So if they died before, we couldn't include their data. And very basic measures of ethnicity and deprivation. Obviously, both of these concepts are complex. So in conclusion, oh, I've talked really fast. Nice. I had done this before and I was at 10 minutes at this point. Okay, I'll do this really slowly. So in conclusion, we have identified some disparities in the delivery of perinatal care according to both ethnicity and deprivation, but a different patterning of those results according to both of those things, which means we think there might be different things going on. And that's important to try and understand because that can help us work towards fixing some of those problems. There are definitely some opportunities to improve equity. So with deferred cord clamping, we are moving towards having to really justify why we do immediate cord clamping. And in fact, we're moving away from using colour as an assessment and using much more objective measures like heart rate now. Admission temperature also associated with mortality, and we need to improve that. Breastfeeding support is very complex because why a woman chooses to breastfeed or not is a very personal thing and very influenced by their culture and background. But that early breast milk should be given to all of those preterm babies because it reduces their mortality. Even if it is complex and involves using an interpreter, it should be done. And parental partnership. These parents need to know what's going on with their children. And even if there's a language barrier or the person seems different from us, that is no excuse for not letting these parents know what's going on with their children. And same with follow-up. It's really important that we follow these children up because a lot of them are at risk of things like cerebral palsy, which have improved outcomes if they're picked up early. So I'm not sure if any of you are neonatologists, but it is a bit of a niche specialty. So thank you very much for entering the world of neonatology with me because I absolutely love it and I hope you have found it interesting. Obviously, I did not do all of this work literally on my own because it does take teamwork to make the dream work. So these are some of my collaborators. They're all absolutely fab. And I would love to take your questions and really love to have any emails from you as well if there's further detailed questions. Thank you so much.
You've done very well. Your interest in packing does come through there, I think. And we are big on breastfeeding here at York Egg Society. Our charity last year was Treasure Chest, a local breastfeeding support charity. My wife used to be a breastfeeding peer supporter. So this is the question, but just to clarify, so day 2 early breast milk is higher in whites but lower after discharge compared to that's just to clarify. So they start off getting it more, but they leave it less often.
Yes.
Yeah.
So they're being helped get that early breast milk, but then choosing not to carry on with it. So yes.
Thank you so much. I'm going to open the floor up to questions here about that very wide-ranging study. Robert, over to you.
These, as a point of ignorance, about what colour the coordinate and placenta is in a child with a dark skin and white.
Oh, yeah.
Does that affect the observation you make in relation to cord?
So the cord is almost always white like this. The only exception is if they've been born through meconium where it's green. The placenta should be red unless there's been a huge antenatal hemorrhage. The baby will be a different skin tone, whether they're even if they're well, amongst Asian children compared to white children, black children compared to white children, and so we're trying to be a bit more objective about that. But I'm fascinated to know, and because it's an observational study, you cannot draw this out from it. Are these children genuinely more sick at delivery, which is possible?
Confounding factors.
Yeah,
Yes, you used to be raised a lot of questions as well as
Yeah,
answers.
I know,
Yeah,
I know.
which is interesting. Okay, thank you. There was another question here.
So, as a part of my training in pantry health, but also in general, I have a bit of background in pediatrics, and I'm very passionate about breastfeeding.
Yeah.
And I was actually quite shocked when I moved to the UK.
Yeah.
About breastfeeding rates. And when I was listening to you, I think that the first 2 days it is about being helped in a ward and having an information during pregnancy. But also, I kind of feel there is a way of, I mean, we need to cooperate because you get these babies when they are born. And you do not meet their mothers before, do you? So
well, we should for most of these babies, the gold standard, if they're going to need to be admitted to the neonatal unit, we are supposed to go and have a consultation with parents before and discuss breastfeeding and even start some antenatal expression. But sadly in healthcare there is this it seems that people find it easier to be a doctor to people who are like them. It's not a sort of deliberate thing, but it seems that is what might be going on.
So would it be, but then you would meet these people when they're admitted and in quite unwell?
The mothers might be, or they might not be. It really depends. So sometimes the babies are delivered because of maternal health concerns. Sometimes the woman's in Sainsbury's and the baby starts coming. It really depends. It's about sort of it's one of those kind of rules of thirds, where a third of the time it's because of maternal health concerns, a third of the time it's fetal concerns, and a third of the time, who knows?
But that's really good to hear that there is also kind of, because I will probably be doing some work in primary care.
Oh, yeah?
This is something that I would like to do.
Oh,
in
well,
the
do get in
future.
touch with
And
me
then I'm
about
thinking,
it.
and I'm thinking, yeah, I did a little bit on breastfeeding as well, do planetary health.
Yeah.
But also I'm thinking it's really good to hear that you're doing something from the.
Oh, yeah, very much so.
perspective, and it isn't last minute and after everything is done and it's too late to do it.
Yeah, sure.
Okay, I think I saw a hand go. That's actually, forgive me. I'm going to go to the final question there to you, sir, at the back.
It's just to say, have you seen it?
Yes, I taught on it yesterday. Yes, so it can be DCC can stand for delayed or deferred cord clamping. So in the NLS manual, I think they call it delayed cord clamping, but delayed can imply a bit of an error or that something's not happened when it should. And so some people prefer the term deferred. But most of the time in hospital, we just call it DCC. But I thought when I practiced this talk to my 10-year-old, she told me I was using too many terms that people wouldn't know what they were, too many acronyms. So I tried to cut out all the acronyms.
Always a good idea, isn't it, really?
But this should potentially cut that out.
Yeah, well, I hope so. Yeah, I hope so. We'll see.
I am allowed to speak, actually. Go on.
So my question is, for how long I've got these results on some good outcomes and bad outcomes, and what have you done in your trust to change to bad ones to good ones and to protect the good ones? And just one minor question.
Yeah.
Who does the clamping? Is it neonatologist or the obstetrician?
So we found that.
The question there.
Oh, sorry.
Who does the clamping?
Who does the clamping, and what have we done about these results? So in terms of what we've done about the results, these are pretty fresh. Whenever I've been involved in any research project, I like to share it a lot, but that's been slightly delayed because I've literally just come back from adoption leave myself. It's about making this clear to people, because I think a lot of people don't realise that it's not just the outcomes down there being like, oh, that's strange, there's more mortality. There is some literal care delivery that we're doing differently. So it's about sharing it, like what we're doing now.
Have you presented it? Sorry for interrupting. Like, have you presented it?
So there's so the National Neonatal Audit Programme, when we did this work, they've picked it up, and now they're going to start presenting results split up by ethnicity to try and address this sort of thing. And then in terms of who does the actual clamping, the obstetricians or the midwives do it, but we have found on quality improvement projects, not specifically looking at ethnicity, but just improving deferred cord clamping generally, having the guidance of the neonatologist to be confident about what's going on about that baby helps to improve the rates of deferred cord clamping. I'm married to an obstetrician, and they are frightened of babies. So they want someone to tell them what to do with the baby. They just want to get rid of it. So he wouldn't mind me saying that. I don't think.
Okay.
Okay.
Thank you very much.
Thank you.
Thank you.
I'm an ST2 in ophthalmology in Harrogate. Thank you for having me today. Don't know how I'm gonna match the last 3 talks. They were really, really good. But yeah, as the title says. So the plan is to talk you through a case, talk about the literature that's out there about this case at the moment, then kind of conclude why I think it's really important to talk about and to present, and then hopefully round it all off. So this was someone we saw in Harrogate Hospital last year. She was a 21-year-old female. She presented to us with 1-day history of a very swollen and sore left eye and reduced visual acuity. Just her left eye, right eye was absolutely fine. She had painful eye movements and no double vision. And aside from this left eye, she was completely well in herself. No precipitating factors that we were aware of, so no obvious insect bites and no trauma. When asked about her past medical history, she said there was nothing of note. She didn't take any medications. She did have an allergy to penicillin. It gave her a rash. And her job, she was a makeup artist. She drank socially and didn't smoke. Examination findings, basically the right eye, nothing really to see there. In the left eye, she had very reduced visual acuity. So for those people that aren't ophthalmology speaking in our foreign language, 4 out of 60 is basically meaning what someone can see with really good vision at 60 meters in the distance. She could only see if that was placed 4 meters in front of her. So imagine a tree back in the distance, so very, very blurry left eye. IOP is intraocular pressure. This is the pressure inside the eye. We want it to be less than 21 millimeters of mercury. Her right eye was 17, her left eye was raised at 36, which makes us worried that the eye pressure is too high. It's going to compress on the optic nerve and cause damage. Examination-wise, she had very, very swollen conjunctiva, so she had chemosis that was bleeding, so it was hemorrhagic. She had this mucopurulent discharge, restricted eye movements, so her lateral rectus specifically wasn't going, so she wasn't able to move laterally with that left eye, and there was a relative afferent pupillary defect. These were her pictures. That looks a lot worse than it is. So she's got some fluorescein staining in there, so her discharge was not fluorescent yellow. But what you can see on that picture is really, really swollen eyelids. Kind of explains the importance of prizing a swollen eyelid open and having a look what's inside. And you can see the bleeding there. You can see the hemorrhagic chemosis. And you can see where we've drawn around it. I don't know if you can see that well, but it's already spreading at the bottom there. So very swollen eye. And not the nicest to look at. So we've got quite a few red flags there for an orbital cellulitis. So just thought I'd recap on why we're worried about this. So your preseptal cellulitis is swelling of the eyelid. This is preseptal, so it hasn't gone past the orbital septum, which is highlighted in blue on the diagram. And then you've got your orbital cellulitis, which is now where we've got involvement behind that septum, so orbital fat, extraocular muscles. So they're both going to present potentially with a fever. She did not have a fever. Potentially with eyelid swelling and redness and pain. But your kind of red flags for an orbital cellulitis is your pain on eye movements, which she did have. Your ophthalmoplegia, so your restricted eye movements, which she had. Your visual impairment, she didn't have any double vision, but what she did have was very, very blurry vision and proptosis, but the eye wasn't proptosed in this case. So loads of red flags there. We're going to investigate it. So following the Harrogate guidelines for orbital cellulitis, I've just zoomed in there on the bits because that's very, very zoomed out. Basically, she needs admitting, she needs IV antibiotics, ideally tazocin, but she's penicillin allergic. So she was started on the IV aztreonam, IV vancomycin, and IV metronidazole. We marked the area. She got herself an urgent CT, bloods, blood cultures, and we did swabs. Oh, this is the old one. So yeah, those 4 things basically. And she was very closely monitored. So on the left is what you would expect to see in a CT scan with someone with orbital cellulitis. That's taken from Radiopedia. Basically, you can see on that left eye there, so left eye, there's some preseptal swelling, but you can also see that the medial rectus is swollen. I wonder if I can highlight that there.
Is it this?
This is so the left image and the left eye, which is right on the picture. So this one that I'm circling. So she's got this preseptal swelling here, and then sorry, this is not her. This is another scan, and then medial rectus extensions. So that's what we're expecting to see. Whereas this was her CT scan. I appreciate it's a slightly different plane. What you can see here is really nice, clear sinuses. Maxillary sinuses are clear. I'm not too concerned about this air here. It's probably just trapped under the swollen eyelid. But what we can see is this swelling here. So you do have a preseptal swelling, but then an extra more whitish area here. So the CT was originally reported as no orbital collection, but they agreed that the sinuses were clear. But what we've seen is a soft tissue swelling at the lacrimal gland with associated fat reaction. So further results, so her bloods on day 1, her CRP was 40, on day 2 you have that lag, so it came up to 153. White cells were raised, neutrophils were raised, but her liver and Usenes were fine. Her swab result came back that we'd swabbed from that mucopurulent discharge and was growing a gram-negative diplococci 2+. She was Epstein-Barr negative and enterovirus negative, and her blood cultures were negative. So we've got an orbital cellulitis picture with a lacrimal gland swelling with a gram-negative diplococci and very high inflammatory markers. Doesn't all very make much sense. When we delved into her GP record, we actually found that she didn't have no past medical history. The year prior, she'd been treated for pelvic inflammatory disease secondary to gonorrhea. So this led us to conclude that she had something called acute dacryoadenitis, so inflammation of the lacrimal gland. Not the best picture here because your lacrimal gland actually, oh, I've lost my mouse, has two sections. It's got an orbital portion, it's got a palpable portion, so an eyelid portion. But your lacrimal gland produces your tears come onto the surface of the eye and drain through the nasolacrimal duct. That's what her CT scan was showing. Most common causes of a dacryoadenitis is viruses, so Epstein-Barr, but she was EBV negative. You've got bacterial causes, so usually staph, strep, those kind of things, but gonorrhea in some cases, and autoimmune causes, so sarcoidosis, IgG4. Usually you get a swelling on your lateral upper lid, kind of in an S shape sometimes due to the shape of that lacrimal gland. You can get very sore eye, you can get watery eye, you can get drooping of the eyelid, a red eye, and fever. So we've got most likely gonorrhea causing a dacryoadenitis, potentially start of an early orbital cellulitis. So we worked closely with our MDT, excuse the appalling AI image there. Tried my hardest. We had daily input help from microbiology. They were using the sexual health guidelines, so the BASH guidelines, to help us when we workshop. It was obviously with your swabs, it's a bit of a delay in response to get that gram-negative diplococci result back. But they advised us to treat with ceftriaxone and metronidazole. She was only penicillin allergic with a rash, so it means we can give ceftriaxone. You have to be a little bit careful with that side chain. It's quite similar to penicillin. So if she was anaphylactic, we might have had to go down a different route. And then we had to work with our gum colleagues to do the contact tracing, figure out why she'd been treated with it in the past, why it's come back, all of that other kind of things. And she was very successful. So after a few days of IV antibiotics, she was looking loads better. Again, that's probably fluorescein crusting around the eyelid rather than mucopurulent discharge. But as you can see, that swelling's gone completely down. She does have a bit of a subconjunctival hemorrhage there, but looking loads better. So delving into the literature now, we could only find 3 previous case reports, and they're all very recent, of people that have had dacryoadenitis related to gonorrhea. So a 24-year-old that it then developed to orbital cellulitis, so similar to our patient. A 27-year-old that then led to a corneal perforation. It required a corneal transplant, which is a huge operation, life-changing operation. And then this year, a 71-year-old male who had dacryoadenitis and scleritis. And that's just screenshots from those 3 case reports, literally nothing else on the literature review there. And then I've just taken this from the BASH guidelines. For the interest of time, I'm not going to read it out, but just after number 30, ocular infection can be complicated by a periocular inflammation and pain, severe lid edema, and orbital cellulitis, but uveitis, endophthalmitis, dacryoadenitis, and symblepharon have all been reported. So we're aware of it, it's just really, really rare. So why tell you all about it today? 4 main things. So first thing first is antimicrobial resistance. So globally, there are strains of gonorrhea that are completely resistant to all antibiotics that are out there, including ceftriaxone, which is our #1 treatment. We are very lucky in England and Wales at the moment. That's a very low, thank you, amount. So in England and Wales, we've not got a lot of resistance, but it's there globally, and it's probably going to come to England and Wales soon and be a very big problem. Then we've got increased prevalence. So in 2023, we had 85,000 diagnoses of gonorrhea. We're luckily back down to 72,000 cases in 2024. But, 2014 rates, we were looking at 60,000. It's a lot bigger. It's going up. In Europe, they've seen a 321% increase in diagnoses since 2014. So, secondly, it's asymptomatic, might be why the prevalence is going up. So 40 to 47% of people have no idea they have it, so potentially spreading it without anyone knowing. And then hopefully what I've highlighted to you all today is it's sight threatening. If you get an ocular infection, if you get an orbital cellulitis, we know it can pass to the meninges, we can know it can cause a meningitis and an encephalitis. So it can also be a life-threatening infection. Just for the interest of time, I'll just with through future of gonorrhea management, but there is treatment and trials out there to hopefully get some oral tablets that are working against DNA gyrase for the gonorrhea, but not out just yet, but promising. So to conclude, gonococcal infection is potentially site and life-threatening. It's really important to recognise it early, and we were quite lucky in this case that we did recognise it early and treated it early. Previous case reports have described if it gets to dacryoadenitis, it can progress to orbital cellulitis and corneal perforation. There's a threefold increase in gonococcal infections and multi-antibiotic resistant strains. So awareness of gonococcal involvement in acute ocular presentations is essential. And thank you to Ms. Mackenzie as well for being here today.
Thank you so much for that. I think it was interesting to start with the case report, but that you broadened the actual importance of that to a lot of other areas as well. And by the way, that cartoon of the sort of outpatient department, the three happy dogs, I want to work in that department. They don't look at all stressed.
Ideal, isn't it?
Them at 3.
Remember to notice that part.
So I'm glad. Did some of you get the diagnosis? Obviously, I had the benefit of knowing the diagnosis before the presentation, but it was an obvious case of dacryoadenitis to gram-negative diplococcus, in my opinion. But thank you very much. Questions from our group here? What's that good question?
Did you prove it?
Yes, so she did have she had the NAT test in, which said it was gonorrhea, and then the culture came back as a gram-negative diplococci. So yes.
After the question, it's a really basic question, but how does the gonorrhea get in the eye? Because you said that lady had pelvic inflammatory disease a year beforehand. So is there a way? Is it sexual transmission or is it some other way?
Yeah. So I guess the thought is she's probably been reinfected. She's been treated successfully the year previously and then been reinfected another way. But usually with ocular infections, it's due to kind of having gonorrhea in the genital area, getting hands contaminated and rubbing the eyes is the most common spread.
External contact,
Yeah.
bloodstream. Yeah. Okay, so I'm going to have the questions. I'm going to ask Nick at the back there.
Really quickly, so I think she'd only had the symptoms for a couple of days prior, and then attended A&E the night before. They booked her into the eye clinic, I think later that day, but she just rocked up that morning saying it's worse than ever.
Right. So you covered the importance of it as well with orbital cellulitis and antibiotic resistance as well, which is a growing worrying trend, isn't it? Really? Yes. Okay, I'm going to ask this lady for the question if that's all right. Yeah.
Sue and I both worked in sexual health for a number of years, and I think what's so worrying actually is the disappearance of so many services. So we're losing so much input into things like contact tracing, and even the opportunities for people to go and get tested when there is asymptomatic. It's so much more difficult for people nowadays, and I just think it's beholden to all of us in all specialties to be aware of sexual health.
Definitely, yeah. Thank you.
Our own lives.
Yeah.
So could I ask the question, did you do contact tracing in this case?
Yeah, so we referred her to the GUM clinic and they dealt with all of that. I think she had a partner that was in the army, so whether he hadn't been treated at the time and then, he's come back home, it's hard to say, but we've left it in their hands to contact trace and treat and screen for other STIs if needed.
Okay. Thank you very much, Hannah, for that fascinating.
Thank you.
Rare case report. Yes, I'm getting a reply back from that. So I just want to thank everyone really very much. I've really enjoyed, and I was able to almost focus and concentrate on the content there, which must be a sign of their quality of delivery and communication there. So what came across to me was the interest, the passion, and the wish to make it clinically relevant. And it reminds me of a quote that I've used before at these meetings, which is, when one candle lights another, it does not diminish from the light of the first candle, which is this idea that, no matter how much knowledge you've got, education and dissemination of knowledge doesn't make you a lesser person. It makes you, in fact, a greater person for sharing it. So thank you for that. We've heard 5 very different subjects today. We've heard pain, cancer treatment, neonatology, infectious diseases and even robotic surgery. I was writing notes as I went through there, but actually I wasn't really able to keep pace with the content. So Alicia, yes, fascinating talk. My mother's on gabapentin, so I'll be pointing her in your direction very shortly to get some. But what I liked about that talk was the idea that you were doing harm reduction. First, do no harm is part of the Hippocratic Oath. You were trying to reduce costs, and you were looking at economic analyses and even green analyses, which I think is very cutting edge stuff. And not only that, you were doing something which is close to my heart as a psychotherapist. You were trying to get people to actually do other things as well. And just listening for 45 minutes, I think, was an achievement in itself, really. I think the patients benefit from just have been listened to continuously by an attentive doctor. That's not to be underestimated as a therapeutic intervention. So thank you for that. That was really good. And then Vincent talked about interventions in Leeds. Obviously, I've just been to Leeds today, actually, and I was very interested to hear about all the different ways in which you can actually perform the nephrectomies for people. But the good thing about that talk, I think, was that it wasn't saying these techniques of cryoablation were for everyone, but for the right patient, the right circumstance, it was going to be, something that you'd want to have available. And like all these talks today, we want to know if people have got, randomized controlled trials of evidence base. And then Catherine talked about neonatal outcomes with some passion there. She had a huge sample size of 124,000. That's personally collected data, was it? No, obviously not. And asked an important question. The answers were more nuanced than I thought they were going to be. I thought it was all going to be about prejudice and things like that, but it was actually a lot about clinical stuff. And I particularly like the findings at the end there that you may be changing your way of assessing delayed cord clamping by moving from skin color to heart rate. I did catch that right, didn't I? Yeah. So I was listening. So that's a really good idea. As for breastfeeding, we all know it can be promoted for the right case there. So I think, but ethnicity and outcomes really important. Then we looked at Hannah's talk was very interesting as well, really, because not only did she cover infectious diseases and an interesting clinical case, but the importance of not losing our sexual health services, proper funding for them, and proper recognition for conditions like orbital cellulitis and those red flag signs. And finally, Yavutz at the end there was talking about what I liked about his conclusion was he's not saying this robotic surgery is the best thing. We should do that. It's the future. He's saying it's the future, but in a very nuanced way, and saying we must put patient safety and welfare first, not be dazzled by new technology, but do proper randomized trials before we introduce it. So I think that was really responsible and mature of you to do that. I think. Overall, I think the only quotation I've got before we ask the judges to announce it, I might ask if one of the judges could perhaps come forward and announce the exciting winner, but everyone's a winner here today. I'm reminded of the quotation that if you steal from one person, it's plagiarism, but if you steal from many, it's research. So thank you for stealing from many people to do your talks today. Except possibly Hannah, who probably looks at one patient, but so that's the quotation I've got. I just want to say, don't applaud just yet, but I'm going to say thank you so much to you. You've really enriched our evening here. We've really enjoyed that. And I'm going to ask if the judges have got a majority vote on a winner. There are 3 of them, so there must be a majority vote. Yes, is there? Right. And is it Barbara, are you going to announce it? Thank you.
Well, thank you to our presenters this evening. It's been a really interesting evening. I've learned a lot as I was a midwife in my former life, and I wasn't used to the sort of leaving the clamp to settle for a while, to not to clamp the cord too soon. So that was an insight for me. Thank you. All the presentations were absolutely amazing. Thank you very much, and thank you for your time coming here tonight. There was one in particular that did stand out, I have to say, and congratulations to Catherine Pettinger. It's a very clear and coherent presentation, and it just captures everyone's, thoughts about, the fact that people from underprivileged backgrounds don't really get the advantage that people from more privileged backgrounds get. And yeah, very sort of relevant point. Thank you. Now I'm going to hand over to
Okay, I
Paul
think
to